from KOLAN Hospital. He will gonna share with us his presentation topics, surgical techniques with conventional valves for the small aortic annulus. Please, Professor, Dr. Floor is yours.
Hello, everybody. My topic is the surgical techniques with conventional valve. Valves for small aortic annulus. I have no relationships for disclose. The patient-prosthesis mismatch was first described in 1971 in Rahim Tula, as the mismatch is considered to be present when effective prosthetic valve area is less than normal human valve. After 40 years, nothing changed, and nowadays the term of the PPM, the patient-prosthesis mismatch, is applied to situations, and effective orifice area of the prosthesis is physiologically too small in relationship to patient's body size. The result is abnormally high, postoperative high in transvalvular gradient. How can I classify it to PPM? If an indexed effective orifice area less than 0.85 is now widely accepted as threshold for patient-prosthesis mismatch. This value between 0.65 and 0.85 is classified as moderate PPM. When the indexed effective orifice area is below 0.65, it is accepted as severe PPM. Depending on studies, after aortic valve replacement, prevalence of moderate patient-prosthesis mismatch varies between 20 and 70%, and severe patient-prosthesis mismatch is between 2 and 11%. It has been shown that the PPM following aortic valve replacement have some negative effects on left ventricular mass regression, recovery of left ventricular systolic function, functional class, quality of life, bioprosthetic valve durability. Furthermore, aortic patient-prosthesis mismatch is also associated with increased incidence of postoperative mortality and morbidity. The impact of patient-prosthesis mismatch is more important in early rather than the late mortality, because the left ventricle is more vulnerable during the early postoperative period than later on. The study examined the relationship between patient-prosthesis mismatch and short-term mortality after operation, and they found that the patient-prosthesis mismatch is strong and independent predictor of short-term mortality patients undergoing aortic valve replacement. In this table, you see while the mortality rate was 3% in the non-significant PPM, the 6% moderate, as you see, the 26% in patients' prosthesis mismatch. Here you see the mortality risk twofold in patients with moderate PPM and 11-fold with the severe PPM when compared patient in non-significant patient-prosthesis mismatch. Here you see the relative risk of short-term mortality according to patient-prosthesis mismatch and post-operative left ventricular ejection fraction. Mortality rate reached the 77-fold when the patient ejection fraction less than 40%. The impact of patient-prosthesis mismatch on survival is still controversial, and several recent studies confirm that the PPM is independently associated with reduced survival, and whereas the report is opposite. This meta-analysis was published in European Heart Journal in 2011. They investigated the impact of the patient-prosthesis mismatch on long-term survival after aortic valve replacement. And they concluded that the patient-prosthesis mismatch associated with increase in all-cause and cardiac-related over the long-term survival. This figure shows the impact of patient-prosthesis mismatch on all-cause mortality. The moderate and severe PPM showed the statistically increase in all-cause mortality. As I mentioned earlier, the patient-prosthesis mismatch has negative effect on physical capacity or functional class after aortic valve replacement. The aim of the study was to determine impact of patient-prosthesis mismatch on physical capacity, and 6 months after aortic valve replacement, stress echocardiography was performed in 3,000 patients. They determined a significant impact of PPM on physical capacity in patients after aortic valve replacement. Here you see the distribution of predicted exercise capacity in patient with or without patient-prosthesis mismatch. They found that exercise capacity is significantly impaired in patient with patient-prosthesis mismatch. One of the important negative effects of patient-prosthesis mismatch is early structural valve deterioration of bioprosthesis. It has been shown that in some studies. In this paper, Fleming and his colleagues investigated whether the patient's prosthesis mismatch are major determinants of the onset and incidence of structural valve degeneration of the bioprosthesis. And they show that patient prosthesis mismatch is independent predictor of structural valve degeneration. As you see, structural valve degeneration more pronounced in patients with patient prosthesis mismatch, and this degeneration starts 2 or 3 years after aortic valve replacement. The important question: how can we avoid patient prosthesis mismatch? The patient prosthesis mismatch may be avoided or its severity may be reduced by application of preventive strategy at the time of the surgery. The first step: calculate the patient body surface area from patient's weight and height. The second, multiply body surface area by 0.85 to obtain minimal effective orifice area that prosthesis to be implanted should have to be avoided patient prosthesis. The third step, choose the appropriate prosthesis from the chart. For example, if the patient body surface area 1.8 meters square, then multiplied 0.85 to obtain minimal effective orifice area to completely avoid patient prosthesis mismatch. Result 1.53. Let's have a look chart. If the surgeon intended to implant, for example, the carpentry prosthesis, the minimum size to obtain effective orifice area greater than 1.53, the size should be 23 or greater. If there is a risk, the patient prosthesis mismatch, and the surgeon should consider mainly 2 options. The first step, implant another type of prosthesis with a larger effective orifice area, such as stentless bioprosthesis, a new generation mechanical or bioprosthesis, and aortic hemograft. The second option, enlarge the aortic root to implant larger prosthesis. Despite some concerns, it may increase morbidity and mortality. There are different options regarding the aortic arch enlargement to avoid PPM. Many groups have reported excellent results using root enlargement. In this paper, more than 100 patients who had aortic root enlargement were investigated. And they finally concluded that to avoid patient prosthesis mismatch in patients with small aortic root, aortic balloon enlargements can be performed with minimal added risk. And here you see the addition of enlargement that didn't increase instance of 30-day mortality, stroke, reoperation for bleeding myocardial infarction. This paper published by Mayo Clinic 2007, and they examined the operative risk of aortic valve replacement with or without aortic root enlargement regarding to avoid patient prosthesis mismatch. This is largest study, including more than 2,000 patients. The final day says aortic enlargement itself doesn't increase operative risk, although it most often required among high patients. And here you see the operative mortality variables, and aortic root enlargement isn't risk factor with death. Some recent studies have reported that the valve hemodynamics are superior with the transcatheter aortic valve implantation than surgical aortic valve replacement, especially in the subset of patients with small aortic annulus. The study was published in JACC in 2009. They compared the hemodynamic performance in TAVI and surgical aortic valve replacement. They concluded that TAVI provide superior hemodynamic performance in terms of the prosthetic gradient and severe patient prosthesis mismatch. And here you see the echocardiographic data. The instance of severe patient prosthesis mismatch was also statistically higher in surgical aortic replacement groups than TAVI. Importantly, it has been noted that superiority of the TAVI, transcatheter aortic valve implantation, in terms of the reduction of ppm was more pronounced, especially in patients with small aortic annulus. Some new generation bioprosthesis may be considered to avoid patient prosthesis mismatch. The sutureless valve may be another option with its spatial design due to absence of sewing ring. It provides a greater effective orifice area. In this paper from Germany in 2013, they compared the result of AVR with sutureless valves and conventional biologic valves. They found that sutureless valves have some advantages, especially geriatric patients with small aortic roots. And at the follow-up data, you see the effective orifice area is significantly higher in the sutureless group compared to the conventional biologic group. The trifecta aortic valve is one of the other new generation bioprosthesis with a small sewing ring, a single sheet of the bovine pericardial tissue externally mounted on the titanium stand, which is designed to achieve a better hemodynamic profile. In this paper published in last year, and the analysis of thoracic surgery, and in the study, they compared 300 patients with the trifecta prosthesis and 900 patients with other type of prosthesis. They found that patient prosthesis prevalence is extraordinarily low in patients with trifecta prosthesis. At conclusions, patient prosthesis mismatch is not rare, but avoidable risk factor cause increased early and late mortality. The risk of patient prosthesis mismatch can be easily determined before the surgery. If the patient prosthesis mismatch anticipated, alternative options should be considered in the light of patient's clinical condition and risk to benefit ratio. Thank you.
Well, thank you very much, Dr. Ergun, about your presentation. It was very informative, and we have received a lot of thanks from the listeners. They said that they benefit a lot from the presentation, and they are willing to come to KOLAN and get some training and master class if possible. Are you open for such kind of collaboration to receive kind of doctors from CIS market for 2 weeks, 3 weeks education?
Excuse me, I couldn't hear you. Can you ask please
Yes,
again?
once more. We have a lot of questions from different countries.
Sure.
Almost the same question they are asking, saying that if they have an interest to come for 2-3 weeks in the same area of doctors to get some education and training in your hospital, are you open for such collaboration?
Absolutely, it is possible. We can open the hospital for everyone. Actually, I'm actually interested in the experience for the minimal invasive surgery. We do especially 1 year, we haven't performed the median sternotomy. We performed all kind of cardiac surgery without sternotomy, minimal invasive technique. That's why also we have great experience. That's why. So if anyone interested in, we are very welcome to come our hospital.
We have a lot of interest from almost 7 countries asking same question.
Sure.
At the moment, 13 countries are participating as doctors. Sure. We have participant doctors from 13 countries. And sure. From 7 countries, same question rise up that they are very much interested to come and get some training and training courses, master classes for 2 weeks, 3 weeks, if you can accept them.
Every time.
Great. Thank you very much for your contribution and for your participation and for your detailed presentation for us. Hope to see you in our next virtual expo to share your knowledge and experience with other countries' doctors as well. Thank you very much.
Hopefully. Have a nice day.
Ladies and gentlemen, we will have about a 9-minute break with videos and promotions, and then we will come back to you exactly after 9 minutes. you.